Yes.
Sure, sir. Good morning, sir. Good morning, everyone.
Good morning. So, good morning, everybody. Welcome back to Saturday Club morning meeting. Uh, we have a very special topic today on coronary interventions by Dr. Chirag Seth. And I request one of our very regular member of Saturday Club member, Dr. Chetan Shah, who is a physician in Baroda. I would request him to introduce Dr. Chirag Seth and conduct the session today. Dr. Chetan Sai has helped me to find Dr. Chirag Seth as a guest speaker for our Saturday Club. So thank you, Dr. Chetan. Over to you now.
Good morning, Satish. Good morning, everyone. Today we have a renowned cardiologist of Baroda, Dr. Chirag Seth with us. He will be talking to us about bench to bedside, the change in coronary interventions. He knows that this is a heterogeneous audience. So he has said that he will be talking about the basics of various interventional cardiological techniques, which has progressed during current era. Dr. Chirag Seth has done his DM from King George Medical University, London. Subsequently, he has taken training in electrophysiology at Escorts Heart Institute, New Delhi. He has 2 decades of vast experience. He's having his own hospital, Rhythm Cardiac Institute. He has several publications in reputed index journals, and he has been invited as a faculty in various national and international academic meets. Over to you, Dr. Chirag Seth. He will be talking for about 40-45 minutes, and then we will have about 10 minutes of discussion. Thank you, Chirag bhai.
Right, sir. So, good morning, everyone. Special thanks to Dr. Chetan Bhai and Dr. Satish Bhai for inviting me for this meeting. And it's indeed a pleasure to be at this meeting. You all need hearty congratulations for keeping the academic flavor of Baroda city alive. And it's great to see Satish Uncle and even Dr. Daksha Madam on this meeting. And kind regards to both of them. And without wasting much time, let's go ahead with today's topic. So I wish to remain simplistic, and I'll see to it that we'll be talking about for the common interest of every attendees. So I'll just share my screen. I had tentatively titled my talk From Bedside to Bench, actually. The reason being that as you grow in your practice, you understand what the principles of particular fields of particular field is in managing a given patient. You come across several failures apart from several successes. And when you encounter failure, you go back to the basics and find out why we failed. So my today's talk is going to focus on these aspects, where our interventions failed and how we can manage the patients better. And this would, in general, bring the focus back to knowing the atherosclerosis. So going ahead, this is the slide showing the first poster presentation of angioplasty in the clinical science in 1978, which was presented as a poster presentation in one of the meetings. And Andreas Grundzig, he performed first in men balloon angioplasty on 16th of September, almost exactly 45 years back, on Mr. Adolf Beckman. So angioplasty as a treatment of coronary stenosis have been with us for almost now 45 years. So these are common perceptions that we have in treatment of coronary artery disease. That is, chest pain means all patients will have troponin and cardiac enzyme assessment. Positive stress test means immediately angiography. Accuracy of angiography in assessing coronary stenosis is almost quite ambiguous. Someone saying that there is a 70% stenosis, someone says a 90% stenosis, someone says 60% stenosis. So there seems to be some differing opinions, and that creates ambiguity in the minds of patients as well as clinicians. Another concept is that stenosis means angioplasty. If you have a triple vessel disease, means a bypass surgery. And stenosis, once treated, we have cured the disease. So these are all common perceptions that we have in society, not only in society, but even our medical fraternity as well. But what is important and what we have witnessed is that the clinical science takes a backseat. Whenever this kind of clinical problems are faced with, The more investigative tools we have, this is natural thing to happen, that clinical science takes a backseat, and we must not forget that we still have to root into what the clinical presentations are and then take help of investigations. So let's see, we have one patient with acute anterior MI who has been treated with angioplasty. Naturally, we know that angioplasty is the treatment of choice in acute myocardial infarction. The patient is receiving dual antiplatelets with aspirin and clopidogrel. He's been regular in the treatment, but he's regular in his smoking also. And what we find after almost about a year is, despite being on treatment, he develops stent thrombosis and angioplasty has failed. The failures are not uncommon, even with bypass surgeries, even with Lima grafts. Lima graft is supposed to be working throughout the life. It is said that it does not develop atherosclerosis. And that's how the superiority of bypass surgery in patients receiving coronary revascularization. But even Lima grafts can fail. We can see here that the Lima anastomosis with the coronary artery has got a stenosis where it joins the native coronary artery. So despite a Lima graft working well, it is the anastomotic disease with the native coronary artery that has gone for a stenosis. So even grafts fail. So it is said that even 7% of venous grafts fail every year. And many patients are not aware that certain graft has failed because clinical presentations have been variable. So there are limitations of revascularization. That is, when you treat a patient of acute myocardial infarction with thrombolysis, that thrombolysis can fail depending on the extent of thrombus burden and how late the patient presents to us for the treatment. Earlier the presentation, thrombolysis works. Later presentation, it doesn't. And then one ends up having complications in the form of heart failure and arrhythmias and sudden cardiac death. You can have graft occlusions. There can be both early graft failures as well as late graft failures. Early graft failures can be even in first 48 hours to 7 days to even 1 month or 1 year. And late graft failures can happen almost a decade later or 2 decades later. You can have stent thrombosis after angioplasty. Again, time frames are variable. You can have failures in first 24 hours to 3 months to 1 year or 5 years. And you can have instant restenosis after angioplasty. Stent, being a metal, evokes a fibrotic response, and that stent fails because of that fibrotic reaction after angioplasty, again presenting as recurrence of angina. So these are limitations of coronary revascularization in current era. So what exactly leads to failure of this revascularization? The reason is that we are treating biological aberrations with mechanical interventions. And therefore the mechanical interventions need to be designed as per pathobiology. So far, those links have not been studied well, and that's why whenever we treat these biological aberrations with mechanical ones, there are bound to be mishaps, there are bound to be failures, and from the failures, we need to learn how we can do better. So, are we understanding atherosclerosis in coronaries well? You have various kinds of plaques in the coronaries. We know that atherosclerosis is an age dependent phenomena. With increasing age, everyone develops atherosclerosis in variety of circulations, and the plaques develop in a vascular tree. Those plaques can be stable or unstable. Those plaques can have differing content. There can be lipidic plaques or a fibrotic plaques. The plaques can be vulnerable for rupture. The plaques are covered by fibrous tissue, so there can be thin cap fibrous tissue or of a thick cap fibrous tissue, and vulnerability of a plaque is different whether you have a thin cap versus thick cap. Thin cap fibroatheromas are prone to rupture. Thick cap fibroatheromas do not rupture easily. And there are additional degrees of complexity of plaque. You can have inflammatory infiltrates with macrophages and cholesterol crystals. You can have calcification, and you can have necrotic core in the plaque. So all these compositions of plaque are important as far as that dynamicity of that plaque is concerned, whether that plaque will remain stable or will rupture and lead to acute myocardial infarction. So we need to understand these atherosclerosis better as far as the treatment of coronary stenosis is concerned. We'll bring a concept of remodeling of a blood vessel when a stenosis develops here. It is simple to understand. So whenever a plaque develops, what happens is it is nature's way of providing adequate blood flow to the heart, and therefore whenever a plaque develops, vessel tries to grow in the diameter so as to maintain adequate lumen. So in this figure, the lower half of the figure, which shows expansive remodeling, you can see that as the plaque develops, vessel also tends to develop enlargement, and that is called an expansive remodeling. And with expansive remodeling, you can see that despite good amount of plaque burden, the vascular lumen is not much compromised. So this is called an expansive remodeling developing in patients with coronary stenosis, and this is common to have expansive remodeling of coronary artery. We have seen expansive remodeling happening in aorta, leading to aortic aneurysms. In coronaries, that does not develop to the extent of development of aneurysms, but yes, some degree of expansive remodeling is the norm whenever a stenosis develops, so as to maintain adequate blood flow. You can have constrictive remodeling also, that whenever the stenosis develops, vessel tends to reduce in the diameter, and there is associated reduction in the vascular lumen. This constrictive remodeling tends to happen in patients who have long-standing significant stenosis, especially chronic total occlusions. So in most instances, it is the expansive remodeling which tends to compensate the flow, and therefore vascular lumen looks adequate, and despite a substantial plaque burden. So I hope I am clear about making understand this concept, and we can discuss it further in the later part of discussion. Uh, so when we happen to see this kind of remodeling, how do we know that vessel has got a particular remodeling? So this is image showing intravascular ultrasound. Intravascular ultrasound is an imaging modality wherein you introduce a catheter inside the coronary, and with the same ultrasound principles, we can image coronary artery from within. So this figure shows in the first half, you can see that this is a vessel lumen, a dark black line. The dark black line indicates media, and the inner dark circle is a vascular lumen. And what you can see from 10 o'clock to 3 o'clock is the plaque. So here is the plaque. So you can see that for this plaque, this is the amount of lumen that we see. And if you go to the another figure, you can see the lumen is very small and the plaque burden is significant. And here, this is what the media looks like. So if you compare the plaque burden here, how do you calculate plaque burden? You calculate the area by media and you calculate the lumen. So total area minus lumen area will give us a plaque volume. So here, for the same plaque volume, you can see the lumens are different. Here the lumen is good, here the lumen is very small. So this is what expansive remodeling does for the given stenosis. These are the two examples which are very elegantly seen on intravascular ultrasound. And therefore, the concept has come that you have a visual and functional mismatch between coronary angiography and the extent of stenosis that you see, meaning thereby not all stenosis are hemodynamically significant, be it a 50%, 70%, or 80% stenosis. What we see is that stenosis is a stenosis of that particular lumenogram, because you do angiography by giving a dye, and that dye opacifies the coronary vasculature. And what you see is the lumenogram. Based on that lumenogram, you tend to say that it is a 50% or a 70% stenosis. But if you have an expansive remodeling, that 50% stenosis can have much more plaque burden. And if you happen to image from within the coronary, it can be almost 80% area stenosis or even 90% area stenosis. Versus you can have 80% stenosis, but you can still have a vessel which is not hemodynamically showing a significant stenosis. So how do you understand that a particular stenosis is significant or not as far as the blood supply to the heart is concerned? The way to find out that is with the help of a fractional flow reserve. Fractional flow reserve is a method in which we introduce a small wire. It is a pressure wire inside the coronary tree, and we measure the pressure distal to stenosis and proximal to stenosis at the level of aorta. And we produce vasodilatation by giving adenosine. We know that adenosine is a potential microvasculature and coronary vasodilator, and that leads to maximum hyperemia. That means maximum blood flow going to coronaries. And during that maximum hyperemia, you find out whether there is pressure drop across stenosis. And if you have pressure drop leading to ratio of less than 75%, that means that stenosis is hemodynamically significant. So this ratio is called a fractional flow reserve. That means pressure distal to coronary stenosis and pressure proximal to stenosis at the level of aorta, you find out the ratio. And that ratio is called a fractional flow reserve. And fractional flow reserve less than 0.75 means that stenosis is hemodynamically significant. And if you have a fractional flow reserve more than 0.80, that means that stenosis is not hemodynamically significant. So we have gone away from telling the stenosis as only the diameter stenosis or area stenosis. We try to find out whether the fractional flow reserve is abnormal for given stenosis or not. So this is one slide showing this kind of mismatch in coronary stenosis. What it shows is that if you have, let us say, 80% stenosis in coronary artery, we are talking of graph A. If you have 80% diameter stenosis in coronary arteries, what are the chances that it will be hemodynamically significant? It is said that there is 57% mismatch, meaning thereby 80% stenosis may not be producing ischemia in as high as 57% mismatch, 57% of people. Versus you can have close almost 40% stenosis, you can have reverse mismatch, meaning thereby those having 40% stenosis, 16% of such patients may have hemodynamically significant stenosis. So this clearly shows how ambiguous our reporting on angiography is as far as the propensity to produce coronary ischemia is concerned. So you have a sizable mismatch between diameter stenosis and their capability to produce ischemia. So not all stenosis are responsible for ischemia. That is the bottom line. Up to 80%, not all stenosis may be ischemia producing. And this has led to the routine assessment of fractional flow reserve has led to absolute number of vessels which we treat as far with the intervention that goes down. So potential triple vessel disease, if you apply this method of fractional flow reserve, you know that out of 3, maybe 1 or 2 are ischemia producing. All 3 are not ischemia producing. And therefore, the patient may need lesser number of vessels treated either with the help of angioplasty or a bypass surgery, or even none. If there may be triple vessel disease, but none of the vessels may be ischemia producing, that also can happen. So routine assessment of severity with the help of fractional flow reserve, when we are trying to find out hemodynamic significance, you treat lesser number of vessels with the intervention and you put more patients on medical treatment with the help of statins and antiplatelets. So that is what the message is from the given slide. And how safe it is. Like once someone develops stenosis, and when we say that this stenosis is not significant, better be on medical treatment, there are going to be some anxieties. That patient will say, oh, I have a stenosis, whether I will develop infarction or not, whether I should go ahead with angioplasty or bypass or not. So this slide shows that when you treat all these patients medically, where the significance is proven that it is not significant with the help of FFR, all those patients do well on medical treatment. You can see that death from any causes, death or myocardial infarction, or need for repeat revascularization, all those endpoints at the end of 360 days, they are significantly shows divergence, meaning thereby it shows that the approach to treat them medically is safe. So coming back to imaging, because ultimately what we need to find out apart from the hemodynamic significance is how the plaque burden is, which I highlighted in my initial slides. So how appropriate are our tools to understand the disease? And here the coronary imaging is the key. We have seen angiography is a well-known tool for understanding stenosis. You have a CT angiography, and now we have intravascular ultrasound, wherein ultrasound waves produce coronary image. And then we have optical coherence tomography. Optical coherence tomography uses infrared light, and that infrared light tends to reconstruct the image of coronary from within. And both these modalities are now in vogue as far as optimizing our coronary interventions are concerned. You can see the extent of resolution that it produces. You can see that with angiography, your resolution is 200 microns, with IVUS it is 100 microns, and with optical coherence tomography is 10 microns. And therefore, our assessment of coronary plaque is best with the help of optical coherence tomography, and to a greater degree even with intravascular ultrasound. You can see from the lower half of the slide what that magnification means. And it can clearly show that intravascular imaging tends to clarify what we are treating in a much better way. So how it does? So how do we manage ambiguity in treating coronary stenosis? When our aim is to minimize further restenosis and failure of revascularization, we need to find out whether the patient has hemodynamically significant lesion or not, and that we can do with fractional flow reserve. And then we have to optimize the stent deployment if we are going for angioplasty. So what are the tools to achieve this? We have highlighted these methodologies. The first figure in black and white shows the picture of intravascular ultrasound, and second is the image from optical coherence tomography. Practically, both images look identical, and we can see that a dark band here again is a media. The inner bright structure is intima, and the outer bright structure is adventitia. And the same thing can be seen here in optical coherence tomography also, that you have a band, a dark band, which is media. The inner structure is intima, and the outer structure is adventitia. So both methodologies almost typically show the same thing. But since the magnification is better with the optical coherence tomography, the plaque morphologies are going to be seen in a much better way if you have optical coherence tomography. So I'll just show you one or two cases to highlight what we do. So let us say this is a 66-year-old female who has diabetic hypertension and who has significant angina on medical therapy. Resting ECGs are okay. Echo is normal, LVH, but no wall motion abnormality. Her stress test is positive. And when we see angiogram, we see that there is some disease in the coronary artery. Just to not going into too much of technicality, her LAD did not show much disease. This is the LAD artery, and it seems to be flowing well. It shows maybe 40-50% plaque, but nothing much. And if we see the right coronary artery, the right coronary artery shows significant disease compared to LAD. If we see here, the right coronary artery shows almost close to 80% disease in the mid segment. So we were very sure that this patient has ischemia because of right coronary artery and not because of left anterior descending artery. So patient had multivessel disease and diabetes and hypertension. She was traveling from Africa for the treatment here. And we did FFR assessment of this patient with giving intravenous adenosine infusion for 3 minutes, and we assessed with a pressure wire. What we found was FFR in the left anterior descending artery was 0.76. So those 50 to 60% stenotic lesions were actually hemodynamically significant. Whereas stenosis in right coronary artery, which was looking at 80%, it was negative. The FFR was 0.94. It was well above the cutoff of 0.80, and that means it was hemodynamically not significant. And even the left circumflex artery that had FFR of 0.90, hemodynamically non-significant. So in the face of triple vessel disease, this patient had two vessels showing hemodynamically non-significant disease and only one vessel showing hemodynamically significant disease. And therefore that patient needed treatment for only single vessel rather than going for bypass. A single vessel with a stent was treated. So this is what the paradox was, that lesions which were not looking significant were hemodynamically significant ones. And here with the use of FFR, we treated that vessel correctly. So we'll show you some of the images, how we see on coronary imaging. This is optical coherence tomography image of a vulnerable plaque, a thin cap versus thick cap. This is what it is shown here, that we can see here from, let us say, from 7 o'clock to 4 o'clock, we can see that there is a dark band of media seen, but the dark band of media is lost in the lower half of this circle, and you can see a substantial plaque burden here and a minimal covering of that plaque burden. So this is a thin cap fibroatheroma, and this kind of thin cap fibroatheromas are prone to rupture leading to acute MI. Whereas if you see the plaque here, you can see a bright structure here, meaning thereby a fibrous tissue here at the layer of intima, and you have lipid collection over here, that is between 12 o'clock to 4 o'clock position. You have a lipid covering here, but that is lipid is covered by a bright structure here, which is a fibrous tissue. So this is called a thick cap fibroatheroma. So you have a thin cap fibroatheroma here, and you have thick cap fibroatheroma here. So this thick cap fibroatheromas are not prone to rupture, and they are less likely to cause acute MI. Whereas thin cap fibroatheroma, even though the lumen looks bright, lumen looks wide open, this can still rupture and lead to acute myocardial infarction. So this is how plaque looks on optical coherence tomography. Then you can see the plaque getting ruptured. You can see here at the level of 2 o'clock position, a necrotic core which has ruptured, and you can see the rent here. And this is how the plaque rupture looks in optical coherence tomography. You can see that here the fibrous tissue has got intimal tear, and here there is intimal dissection, which again is responsible for development of thrombosis at the local site. So with the help of intracoronary imaging, when we understand that particular plaque morphology, we can have different types of plaques. You can have a lipidic plaque, you can have a fibrotic plaque, you can have calcific plaques. Here you can see from 9 o'clock position to 5 o'clock position, a dense plate of calcium. And that calcium is very well seen on optical coherence tomography, and it is a modality of choice to see this. Here also you have a severe calcification right from 4 o'clock position right up to 12 o'clock position. And here you can see that the thickness of the calcium is also significant. So when we see this kind of plaque morphology, we tend to apply appropriate tools to treat this kind of stenosis with the help of either non-compliant balloons or cutting balloons, which can cut through this plaque and achieve a good lumen. Uh, because with severe calcification, your regular balloons may not be able to inflate that stenosis well, and one can have a failed intervention. So this kind of plaque morphology helps us for lesion preparation before putting up a stent. Not all angioplasties are same, not all coronary stenosis are same, and therefore imaging modality helps us in choosing the right tools to treat them. So with the help of imaging, when we put a stent, we tend to find out which is the best site to land the stent. So, what is the best site to land the stent? The stent should start and land into the area where there is no plaque burden or a minimal plaque burden. We call minimal plaque burden when you have a plaque burden less than 40%. So, if your stent lands to area where the plaque burden is less than 40%, chance of that stent failing is minimum. So let us say if this is the example, the optical coherence tomography shows a longitudinal view of that particular vascular lumen, and the black portion in the upper half of this image shows a lumen. So based on that lumen, we find out where the widest lumen is available, and from those widest lumen, we try to find out what the plaque burden is. And here you can say that in this first figure, we can see that there is a plaque from 3 o'clock position to 5 o'clock position, but rest of all, it shows good medial structure around and good lumen. So this is the right area to land the stent distally, and proximally, the last image here, we can see media all around, and this is a site where the stent should start. So this gives us accuracy as far as where the stent should be put, from which to which point, what kind of plaque morphology is, what is the size of the vessel, and accordingly you can size the particular stent and you can optimize that result. Chance of this stent getting restenosed if when properly deployed is going to be minimum, less than 3% to say. Versus if you don't use imaging, that chance can be high. When you apply imaging, one tends to find out various reasons for stent failure as well. You can have stent fracture leading to restenosis. You can have underexpanded stents, and you can have calcification and new atherosclerosis leading to stent failures. So intravascular imaging like this tends to give us a three-dimensional image of coronary vessel being treated. You can see the fly-through image taken within the coronary. You can see a cross-sectional image here, how the stent is deployed, and you can see a longitudinal section of that particular coronary being treated. It also says how good your stent is deployed. When it shows that stent studs are bright white, that means stent is well deployed and well expanded. Particular stent studs, if they are seen in red or yellow, that means stent is not very well opposed to the vessel wall, and we need to do job here better. Do a balloon dilatation here and see to it that the stent is deployed well. If you don't do this, then these are the stents which are likely to have stent thrombosis or even higher chance of restenosis. So imaging tends to show us this way. Let us say in this image, you can see here between 30 and 40 mark here that the stent is relatively under deployed. You can see that it is not very well expanded here. We need to expand this portion well, and then only this result can be good. Otherwise, the chance of restenosis here will be higher. So imaging has helped us in this way in optimizing the angioplasty and showing us where we need to do the job better. This is one slide showing that the two sites of stenosis which are treated very well, it luminally angiographically, it shows that the lumen is very good and the vessel is very well open. But if you see the imaging, you can see that imaging for the first lesion, it shows a good lumen symmetrically opened versus the second lesion, which does not show a good lumen opening. It has shown irregular opening, asymmetrically opened, and here the job needs to be done better. So this is showing the limitation of regular imaging with angiography versus coronary imaging with optical coherence tomography. And once you see this, you optimize it better, you remove all these asymmetry with further balloon dilatations, and then the stent can do well. So no longer angiographically good lesion should be considered good as far as long-term prognosis is concerned. This is one slide which shows a very important pathology that is called endothelial erosion. We come across so many young people developing acute MI. In all those patients, if you happen to see on coronary imaging, you can have just coronary endothelial erosion. There is no plaque burden here. It is just endothelial erosion, either because of history of smoking or let us say hyperhomocystinemia, B12 deficiency, endothelium becoming unhealthy that tends to have rupture. In young patients, this is the commonest pathology leading to acute MI. Why it is important to know, all these patients can be treated conservatively with the help of only thrombosuction or thrombolysis. These patients may not require stent, and therefore we can avoid metal in all such patients having acute MI. But this can be diagnosed only if you employ coronary imaging as a tool, otherwise one cannot find it. So this is one important pathology we have come across in young patients. This is one another example of coronary stenosis. We can see here that patient has a left main stenosis, and this patient has had a previous angioplasty done to LAD, and this patient has come for evaluation that how best to treat. So naturally, one would say that yes, bypass is the answer for this patient and should go for CABG once the stent has failed. But the patient was at high risk of surgery, and somehow we had to treat this. And we employed intravascular imaging to find out what has happened to this patient. So when we saw with intravascular ultrasound, what we find was that here the media to media vessel size was high, it was 4 millimeter, but the initial stent put was only 2.5 millimeter. So when the stent was undersized, this patient was likely to develop restenosis, and it was because of that restenosis that patient had developed stenosis and recurrence of angina. So when we treated that patient with a repeat balloon angioplasty, we uptitrated the balloon sizes and led to almost a 3.5 millimeter of lumen diameter gain here. And we treated the left main bifurcation with angioplasty, and now almost over a period of 3 years, he clinically is doing well. So this is the end result of that angioplasty that we had done with image guidance with ultrasound, intravascular ultrasound. So all these things tells us that we need to look beyond the angiographic result. Nowadays, what we see is what we assess is that the lumen areas are important as far as coronary imaging is concerned, not only angiographic success. And this is called the rule of 5, 6, 7, 8. At LAD ostium, the area should be 6 millimeter square. In circumflex, 5 millimeter square. In left main, 8 millimeter square. And in large persons, it is called a rule of 6, 7, 10, that LAD should have 7 millimeter square and left main should have 10 millimeter square. So if we have not achieved this, then probably our job is suboptimal, and that patient is still likely to have failed intervention later on. This is one example of graft failure, and the patient had a significantly calcific left main disease. Graft to this artery had closed, and we had to treat this stenosis here. So how did we do that? When we dilated this with the help of balloon and we checked the coronary, what we found was that there were thick plates of calcium. You can see from 1 o'clock position to all around. It was almost a circumferential calcium with a thick plate, almost more than 0.9 millimeter. And this thick plate of calcium cannot be really treated with cutting balloons or any part of balloon. So what we employed was an intravascular lithotripsy. We know lithotripsy in urinary calculi. It's an established mode to treat urinary calculi. And now lithotripsy is available for treating coronary calcium. It is called intravascular lithotripsy with the help of balloon. We go to the site of stenosis, and then we give ultrasound signals through transmitted through that balloon, and that ultrasound signals tend to break the calcium. This method is called intravascular lithotripsy. And with appropriate sized balloon, when we treat with you can see that balloon is gradually getting inflated as the intravascular lithotripsy waves are given to the stenosis. And this tends to now give good result. You can see in the lower half of the image that despite that degree of calcium, that stenosis can be very well seen that it has been treated nicely and it is documented on optical coherence tomography. And you can see how nicely the stenosis is opened after angioplasty with the help of intravascular lithotripsy. So, what is the current role, current status of invasive imaging as far as coronary stenosis is concerned? It is said that fractional flow reserve study should be done for all patients who have stable multivessel disease. It should be employed in all patients who have stable coronary artery disease and those who have multivessel disease to find out what the culprit lesions and culprit vessels are, and accordingly treat those vessels either medically or with intervention. Intravascular ultrasound and optical coherence tomography should be employed whenever possible. The indication is class 2A in a given patient with coronary stenosis. And it is having incremental role in patients who have left main disease and those who have stent failure and complex lesions in the form of chronic total occlusions and bifurcation angioplasties. This is one last example that I would like to show. This is the patient who had anterior wall MI, and you can see here that LAD has got a critical stenosis, and that LAD had a very significant calcium. And this patient was almost 79 years old and had a critical aortic stenosis, unlikely to go for CABG surgery in this setting. So we thought that we will give a palliation with the help of treating the stenosis and salvaging the acute MI situation. Due to heavy calcium, no balloons could really cross that lesion. And ultimately, what we employed here was a rotablation. Rotablation is a methodology wherein you can ablate that calcium which is there in the coronary with the help of a diamond burr, which contains diamond burrs at its tip, and it can ablate the coronary calcium. And once that coronary calcium is ablated, you can very well dilate that calcium, and then balloon dilatation in stenting is possible. And after this rotablation, what we saw was that the stenosis could open very well, and patient could be successfully salvaged as far as the acute infarct was concerned. And this is how the end results of that stenosis looked like. So I will end my talk with these last two slides, that angioplasty with stent will have good long-term outcomes when the indication is ischemia guided. So this underlies the fact of relying first on clinical data and importance of history taking. In stable patients, it should be FFR proven when the severity is borderline. It should be treated with a third generation drug-eluting stents. Dual antiplatelet statins and measures for risk factor reduction are optimal, and stent deployment should be optimized with coronary imaging to have a good long-term outcomes. Bypass surgery can have good outcomes when the grafts are supplying the vessel with hemodynamically significant lesion. One of the reasons why grafts fail is that despite 80% stenosis, if the lesion was not hemodynamically significant and if you have attached a graft to that vessel, that graft will definitely fail. So grafts should be given to vessels which have hemodynamically significant value attached to it. The target vessel should have good size and it should not have a significant disease distal to anastomosis. Liver graft should be given to LAD. You may come across a lot of patients getting venous graft to LAD, which is not the standard of care. Patients must get lima graft to LAD, and especially in patients with diabetes and LV dysfunction and multivessel disease. Venous grafts any day are much inferior to drug-eluting stents in current era. So if the patient has received a venous graft to LAD, naturally his long-term outcome is not good, and one has to ensure that patient gets a lima graft to LAD. And revascularization should be considered for territories which are viable. At times, territories which are necrotic in the setting of LV dysfunction, it is of no use revascularizing those territories which are showing a necrotic myocardium. So lastly, how the interventions are different today. Nowadays, we have considered intralesional thrombolysis rather than intravenous thrombolysis. Like if you have a substantial plaque burden, you can go with the catheter within the plaque, and you can give lower dose of intralesional thrombolysis. So here the dose of thrombolytic will be small, and naturally because of that, even the bleeding complications will be much less. But this is still science in evolution. It has still not found a uniform recommendation for all patients. So it is done in selected cases with a high thrombus burden. No stent if endothelial erosion is found in the situations of ST elevation MI on optical coherence tomography. I've shown the image in young patients. If you get endothelial erosion, don't stent them. Just treat them medically with a thrombosuction and put on hydrostatin and antiplatelets. No stent in such situations. Thirdly, the plaque characteristics decide how to treat based on calcific plaque or lipidic plaque or how it is. And accordingly, you choose your modality before putting a stent, which optimizes the result of the intervention. Physiological lesion assessment is important in stable coronary artery disease, and that improves the long-term outcome. And rotablation, intravascular lithotripsy, laser, and brachytherapy, they are now evolving and now almost an established role in treating complex coronary lesions. So thank you for a patient hearing, and you'll be eager to answer your queries and questions.
Thank you, Dr. Chirag Bhai. It was an excellent talk. You really simplified it very nicely, and a very complex talk.
Chirag,
has
you
been
may
made
stop
very
sharing
simple.
the screen.
Yeah, sure, sir. Yeah.
So now the house is open for any questions. I have a couple of questions, Chirag Bhai.
Yeah.
Can you tell us something about the role of calcium score, and is calcium score, can it replace OCT to find out the level of calcification?
So basically, calcium score is derived from imaging. Like without calcium score, the tool to assess that calcium score is imaging. So calcium score is important. I mean, if I frame your question correctly, are you talking of calcium score based on coronary CT?
No, yes, CT scan.
Yeah. So let me tell you, coronary CT is an inferior tool. It just says extent of atherosclerotic burden. It does not really say how significant that calcium is at the level of a plaque, and it does not guide us how to treat those vessels. It can just say that this patient has a significant atherosclerotic burden, and it doesn't say hemodynamic significance of those lesions. So it just says calcification and extent of atherosclerosis. That's all. So it cannot really replace the need for physiological assessment. It does not replace the need for invasive imaging if patient undergoes stenting.
Like, in practice, what happens, many patients come to us and they say that we would like to know about our coronary status, but they don't want an intervention.
Yeah.
So in that case, do you think that calcium score or CT coronary angiography would be better?
As a cardiologist, we have refrained from recommending a routine use of CT coronary angio or any invasive assessment. I think even in current era, understanding the baseline risk factors and at the most stress testing is good enough, because ultimately, even after positive stress test, you are going to do the same thing what you do it based on coronary CT evaluation. So why to give unnecessary radiation? So at times, knowing more than what is needed tends to provoke more anxiety. So in our routine practice, I think we stick to the same thing, that assessment of coronary risk factors and stress testing should be good enough.
Okay, thank you.
Optical coherence tomography, how routinely you use? Is it similar to laser?
Optical coherence tomography is our penetration to use in coronary intervention is close to 15%. We are unable to use in all, mainly because of cost dynamics. It uses infrared light to generate images. Laser is different. Laser is an entirely different modality. It is not an imaging modality. Optical coherence tomography is imaging modality. Laser is a treatment modality. And currently the laser is being used for treating instant restenosis, and at least 5 or 6 centers now in India are equipped with providing laser for coronary stenosis.
Chirag, how OCT is done? Does it need femoral or radial is enough?
You can do from either axis. You can do radial or femoral. Vascular access does not really matter. It is similar to angioplasty, that you put a catheter inside the coronary tree and then put OCT catheter, flush the system with contrast, and introduce a catheter that takes the image. It is an automatized pullback as far as constructing images are concerned. And we can really, if interested, we can really show live in one of our case presentations for understanding everyone how it is done and how it shows.
Yeah.
A question about
It's a new
preventive
modality, so
oncology.
it will be interesting.
Yeah.
And what would be the cost difference? Because if 15%,
Yeah.
according to your presentation, I would think that you should be using it more often.
More frequently. Yeah. So,
Yes.
so to give you perspective, Korea and Japan are using in more than 85% of cases of intervention, whereas US and Europe penetration is 30 to 40%. So you can see where we are standing. So it should be used in sizable number of patients wherever possible because it tends to have good outcome. The cost is additional cost of about 65,000 to a routine angioplasty. So
And how much would be FFR?
FFR is we have come down to a cost about 15 to 20,000.
But then why most of the centers in Baroda are not using FFR? I have hardly seen other centers using FFR. Any
I
particular
think,
wanted
reason?
to know how much time it takes. If I get an acute MI and I go for angioplasty, so will you, in that way, on that basis, will you use OCT or you will just go put in a stent?
Yeah. So depending on hemodynamic stability, one would still consider that if a patient is unstable, what we do is we put a stent and then do OCT rather than wasting time in doing imaging. So when you do imaging, it is the accuracy which is more important. The perfectionism that you tend to bring into that intervention, that is more important. And it adds to only 10 minutes more. It does not add more than that in routine use of imaging. Our system is now well equipped to provide that degree of rapidity as far as intervention is concerned. It adds to 10 minutes more only.
So you decide on the table whether to use OCT or not.
Yes.
So one question which I wanted to know about that CT angio Dr. Chetan Bhai was asking.
Yes.
Say, for example, a normal person who is otherwise asymptomatic and having some high risk factors and he goes for a CT angio and CT angio is normal. How much is the specificity of that? How much we can depend upon that?
So as I told you, I will still go by the risk factors. If you have high risk features, I would still consider more than 2 high risk features of coronary stenosis if they are there. And these patients should be treated with, despite normal CT angio, one would still consider treating them with high dose statins. Our approach will rely more on clinical parameters, less on CT.
He's having hypertension, dyslipidemia on statins, but asymptomatic. He's not having any angina. Diabetic is there, so that's why they want to know coronary status, as Chetan Bhai was asking. And CT angio is normal. Would you put him to further testing or not?
Yeah, we should do with the testing with the help of stress testing.
Okay.
Regarding preventive oncology, if a 25-year-old man comes with high homocysteine, what is the management?
So we can have two scenarios which leads to high homocysteine. Either they are purely vegetarian and therefore their vitamin intake is low and therefore they have high homocysteine, versus they may have they are going to be smokers and heavy consumption of tobacco, which ultimately leads to reduction in which leads to high levels of homocysteine. So based on the scenarios encountered, we need to have a risk factor modification and treat hyperhomocystinemia.
Yeah, there is a question from Dr. Kiran Shah to Chirag Bhai. Do you recommend OCT and FFR in all single vessel disease?
So my recommendation would be FFR for all intermediate severity. Intermediate severity means now almost up to 80% stenosis. Now no longer we consider 50% as intermediate, we consider 50 to 80% as intermediate stenosis. And if you have a mismatch between clinical symptoms and the extent of stenosis, FFR is recommended. FFR is recommended in stable coronary presentations. Will not recommend for unstable angina, will not recommend it for acute MI, but a stable coronary artery disease, meaning thereby effort angina. And if you have a mismatch between what you see on angiogram and clinical presentation, yes, FFR is required. And also in the setting of multivessel disease.
Any other question?
Where is OCT and FFR available with other centers?
I think OCT is available with Pankaj Heart Institute also. Intravascular ultrasound is available at Baroda Heart also. I guess both leading centers are equally equipped with coronary imaging.
Okay. Any other question?
Right.
Okay. Thank you, Dr. Chirag Bhai. It was a very informative talk.
Yeah.
And we would wish you to give us a practical demonstration, as you said. You can put it on the group so that some of us can join it.
Sure. In one of the meeting, it will not take much time. Maybe we'll get half an hour of your time would be enough to show you even live during such meetings. And we can very well time it in one of the Saturdays, in one of the Saturday clubs also, it may be possible to show in one patient.
Yeah.
Great.
Sure.
Okay.
Right,
Thank you.
Yeah, that will be wonderful. That would be wonderful.
Yeah. We'll organize in one of the days.
Saturday.
Definitely, sir. Yeah, we can do that.
Oh, Dr. Satish, you are still there. You can conclude the meeting.
I'm just no. We can end the session now. I'm on the way, so the connectivity is very unstable.
Oh, okay.
Thank you, Chetan, for handling the whole session and moderating it so well. And thank you, Chirag Bhai also.
Thank you.
We can
Thank
end
you,
the
sir.
session.
Yeah.
Thank
Thanks.
you.